Good morning. If you were there last year, I was wearing a full suit with jacket, so we're going to give this a try. Maybe next year it will be no tie. We'll see. All right, so it's an absolute honor to be invited back. I had a great time last year. We were only able to be there for one day, but this year I made it my mission that I was going to be here for the whole time, and it's been wonderful. So thank you so much for the invitation. The talk that I'm going to give you today will seem familiar to the people that were there last year, and I've added a few additional things that if you guys have questions about it, we can go more into. But this is meant to be very much about you. This is very much about sort of having a discussion. So I am going to prompt you to ask questions as we kind of talk about each of the topics. My only ask is to keep them short and keep them generalized. We will have plenty of opportunity to talk about the specifics of your child or the concerns they may have. But I think if you keep them kind of general, it'll help the other families that may have a similar concern. So stop me, raise your hand or just yell it out, whatever works for you all. So these are some of the topics that I would like to cover, and there's a reason why they're the most common that we see in your children. And so I figured we would start with those, and then as questions come up, I'm sure we'll get much more detailed and into the weeds. So what are the most common GI manifestations in children with chromosome 1p36 deletions? Not surprisingly, this is going to look very similar to just about any GI condition in pediatric, but by far, constipation and reflux are incredibly common. And these are the things that I'm sure you all have experienced with your children and have a lot of questions about. So I'm going to spend a lot of time in those two. Starting with probably what is my favorite topic to talk about, which is poop. I have poop emoji socks that I forgot to bring with me, and I was very sad when I realized that. But this is by far my favorite topic to manage and to talk to families about. And so it is also very common in our children with monosomy 1p36. So we have a definition. We don't know yet if it's any good, but our definition of pediatric constipation is the following. We have constipation side effects, or constipation symptoms, I should say, which will be straining. It'll be sort of the sensation of not getting everything out, sort of incomplete evacuation. And then we have other features that tell us how bad the constipation is. Things like lumpy or hard stools. My favorite is, have you ever plug the toilet with just your poop? That's probably my favorite question. And this is like all over super prestigious journals, that is one of the criteria for constipation. And then obviously, the frequency of the poops is also important, but less so for pediatrics. For adults, it seems to be more specific. One thing that I get a lot of is, Doc, how can you tell me that my child is constipated when they're having multiple soft stools every single day? And that's fair. And I also will tell you that you can be very, very severely constipated if that is all you're seeing. And so the idea is this concept called encopresis, which is essentially overflow incontinence, where you have a large stool ball in the rectum that is either preventing the child from evacuating completely, or actually working as a bit of a stent to stent open the anus, causing fecal incontinence. So yes, your child may be having multiple soft stools, sometimes even diarrhea-like stools every day. They may be severely constipated. So just something to keep in mind. What causes constipation in the individuals with this condition? It's multifactorial, as everything else is, but they're at higher risk for developing constipation because of this idea of hypotonia, right? Low muscle tone. And believe it or not, the process of defecation requires a lot of different muscle groups, both smooth and skeletal muscle, and also the ability to bear down, right? This is what creates the intra-abdominal pressure to push out the poop. And so hypotonia is one of the reasons why we believe that your kiddos have such a hard time with constipation. Some of them might be having something called subclinical hypothyroidism, right? So a low or a poorly functioning thyroid condition can cause the constipation. That can be the only symptom that the child may be having. Medications effects are huge. A lot of your kids are on antiepileptic medications. Those slow the gut to a crawl. Now, I'm not going to change somebody's stable medication regimen for constipation because thankfully I have a lot of ways of treating through that medication effect. Anytime that you have a child that is neuroatypical, you're going to run into the issue of withholding. You're going to run into the issue of sort of this dyssynergia or discoordination, because if you think about it, we have a lot of control of when we decide to go poop, right? It is a cultural thing that we have decided that poop occurs in a toilet only, and so taking a baby from going every, multiple times a day in a diaper whenever they feel it, to now asking them to sit down in a strange room and do it only at specified times is a big deal. So when you add on to that things like ADHD, autism, global developmental delay, you're asking for constipation essentially. Dehydration and low fiber diets are also a big issue in general, and so making sure that your children are receiving the amount of free fluid that they should every day. And that may not come necessarily just as water. It can be other things that bring fluid to it, but talk to your dietitians to make sure that you're meeting those goals. And then prolonged immobility, right? There's a reason why, if you go running, you might get the urge to poop, because all those muscles all work towards moving the colon, the large intestine along. Some of those things we can treat on their own, but sometimes we're still left over with constipation. And so this is kind of the pyramid scheme of the basis of management of constipation. The base is the most important, which is education. Educating the parents, educating the kids, educating your pediatricians as to sort of what things can make constipation better, how else can we manage this, how should we be taking these medications. So the education part should be where you spend the most of your time talking to your GI doctors. From there on, we move on to kind of our over-the-counter medications, and these are sort of your laxatives, your Miralaxes, your milk of magnesia, your mag citrate, lactulose, you have Senna, you have Bisacodyl, lots of options that are over the counter. From there, we move on to the new medications, and these medications typically start off as adult medications, prescription only, and they're slowly sort of trickling down to pediatrics. This past year, linaclotide, Linzess, was finally approved for 6 and up, and it's been a great go-to if we feel like we need something a little bit stronger, a little bit newer. From there on, you're kind of talking about more hands-on, more surgical things. So an antegrade continence enema or an ACE might also be known as cecostomy. It's a little G-tube that hangs out over in this side. It gives you direct access to the large intestine, allows you to give your child an enema forwards as opposed to having to use the rectum. And then more niche things like nerve stimulation, like sort of like the sacral nerve stimulator, and I can go over those in detail if you guys want later or during our Q&A. Ultimately, the things that are really going to make a lasting difference is making sure that we are setting them up for success, right? So I anticipate that this may not be a realistic thing for everybody with motility, with mobility issues, but there are a lot of great adaptive tools out there to make sure that your child's defecation posture is what it should be. I think of it as the thinker's pose, sort of the famous a statue. Making sure that your knees are elevated above your hips is very important. And I don't know if you noticed, but the toilets in this hotel are lower than usual. And so the toilets that you're using in your hotel room is actually the way every single toilet should be. Honestly, we should all be squatting to poop, but that's as good as it gets. So take a moment next time that you go poop during your stay here. These toilets are the appropriate height, or get yourself a squatty potty, and that's for everybody, not just your kids. So making sure that you're optimizing the posture, scheduling sitting times even when the child doesn't have an urge can be another way to combat constipation. Keeping a stool diary doesn't have to be anything sophisticated, plenty of apps out there. And then we really need to start considering constipation as a chronic disease. To me, constipation is no different than hypertension or other cardiac conditions. So it is really important that we start thinking of it as a disease and not just as a nuisance. So again, I could talk to you for hours about constipation. I really want to know what you all want to, what questions you have about constipation. Is it the medication, the management, the education? We can get into the really specifics of your child later, but do you have any general questions about constipation in your children? And I have a few things here that we can also discuss.
Hi, so constipation is a very, causes a lot of problems for my daughter. I don't know if you've heard of kids having more seizures if they're constipated, but that's what I've found, and I just wondered if you had any thoughts on that.
Absolutely, not just seizures, right? Any medical condition can be exacerbated by constipation because the way that the body, the nerves that it uses to tell whether there's something wrong in the gut are very different than the ones that you have in your skin. And so sometimes they have the effect of like dysautonomia, for example, sort of not having a disorganized autonomic system can be caused by severe constipation. We know that kids with 1p36 have altered pain thresholds as well, right? And if you add autism onto that, you're really looking at somebody that's very stoic, who may be not hiding on purpose, obviously, just doesn't feel it, the effects of terrible constipation. And sometimes the only way that they can tell us is by having more seizures, by having more violent, self-harming, or sort of mood shifts. So yes, I have seen it cause more seizures. And in fact, one of the, not to bring any controversy into this, but one of the big concerns that I get a lot from my parents is Miralax causing behavioral issues? And what we're actually finding is that it's poorly managed constipation that's most likely what's at fault, and Miralax just happens to be in the picture. So we're still trying to figure that the answer to that question. But yes, severe constipation can show up in many different ways, including lowering the seizure threshold.
Okay, this is kind of twofold for me. First question is, his cardiologist has put him kind of like on a gluten-free diet. And I mean, I'm not, a nutritionist. I don't know. Is he getting enough fiber? He can't have bread. He can't have pasta. He can't have rice. None of the good stuff that we want to eat. And secondly, I do use Miralax when he does get constipated. But what problems can occur from that if I'm using it over an extended period of time? And also, I'm so sorry, also, he is non-ambulatory, so he is in a wheelchair. He'll butt scoot at home, but like when we're out and about or at a day program, he is in a wheelchair. And sometimes I think, well, he's been in the wheelchair too long, he's probably constipated, but then nothing happens when we go to the bathroom.
I'll start with the first one. So sometimes gluten-insensitive patients or patients with true celiac disease, the only symptom can be constipation. So it is a treatment for that in that way. I think as long as we are as long as the child is getting, I would say ideally 2 to 3 portions of fruits and vegetables, ideally they should be raw, not cooked. But there are many other ways to get your daily requirement of fiber, even in somebody that is that is gluten-free. So I would talk. It's as easy as Googling it. There's a lot of great sources out there. I know GIKids.org provides a lot of great nutritional resources for that. But yeah, we know in pediatrics it's important to meet your daily requirements of fiber. What we also know is that giving additional fiber on top of that does not work as well as it does in adults.
Okay, I know you mostly study pediatrics. My son is 36 years old, so I kind of don't. It's like he's not a pediatric. Right. He's right. A full-grown man.
In general, I think making sure that he's getting enough fiber and free water are going to go a long way. Yeah, mobility, I mentioned it. Hypomobility is a very common reason for somebody to be constipated, right? And so it's why sometimes during our newborn well visits, we might tell the parents to bicycle your baby's legs to try to get him moving. So very similar. You can try to do something similar to your child. And I don't know where you're from, but we're very lucky in Michigan to have excellent pelvic floor physical therapists that work with pediatric patients. And one of the things that they do is belly massages to kind of try to get the stool moving manually from the outside and do essentially what somebody that walks a certain steps a day or that goes running once a day, what effect it would have.
Any PT or OT unless we get a private PT or OT.
I'm sorry.
And, that's the state regulations. We're from Colorado.
I have resources that I can share, specifically exercises that you can do at home that some of my pelvic floor physical therapists have given me. And I apologize. Your second question was chronic use of Miralax. We can have an entire hour-long discussion about how much the big controversy and the discussion behind Miralax. I can tell you that I have patients that have been on Miralax for multiple years. I've seen patients that have been on Miralax for their entire lives. If it doesn't have to be Miralax. We have many other options. I get if you're scared about Miralax, and I'm not going to push that on you. Thankfully, I have a lot of options other than that. But I will tell you, I use it on my own kids. If I had to use it chronically, I would still feel comfortable doing it on my own kids as well. And so take that for what it's worth. I think that the data that's out there, it tells me that it's a safe medication, and that the concerns that are currently being figured out are fair, and I think that we need to look at them. But I guarantee you, we're going to having this discussion in 10 years, and we're going to hopefully be able to say that it's safe. Maybe one more question for constipation. Again, we'll get another chance to have this.
Sorry, I'll be quick. So I have twin daughters, and they are almost 3, so they're small, and they've struggled with constipation. And we are on Miralax, but anytime their stool is like even slightly hard, they are in so much pain. Like, why is that? Is that the hypotonia? Is that normal? Like, they like scream when they poop if it's not like runny.
Yeah, that doesn't surprise me, right? In the sense that, yes, we know that 1P36 kiddos have they have a higher threshold for pain. Now that's usually sort of kind of the pain from something like appendicitis, something, like these are the kids that come into the hospital, unfortunately, already perfed because they didn't realize that they had appendicitis. But the rectum and the anus is incredibly sensitive, and it's made that way for a reason, right? You want to be able to tell when there's something down there, and so especially with babies, we see this in perfectly healthy newborns as well. We call it infantile dyschexia, and it's sort of this idea that they haven't quite figured out which muscles to contract and which to relax around the same time, and so that's kind of like almost their way of grunting and pushing and bearing down. I would encourage you to have your pediatrician take a look at the anus. Just make sure that there is no fissures, making sure that there's nothing that could be causing, a small hemorrhoid perhaps, because those can also be very, very painful. And so, keep the stool soft. I think eventually they will outgrow the pain, but just make sure that we're not missing something like that. Cool. We'll go back to constipation, I'm sure. The next topic that I wanted to talk about real quickly is growth and feeding concerns in your kiddos. And so it is very, very common to see both. And it is very, very common to see both in the same child. We don't have a lot of studies in this population, but the ones that do have tell a very interesting story. So here you have two sets of growth charts in males and in females, and you can see that early on in life, they tend to be very, very low weight, very, very small. But that changes much later into life. So we're now talking, early childhood, middle school years, into teenagehood. A good number of them seem to split. Some of them continue to just be small and will most likely just be that way for the rest of their lives, while others take the opposite the opposite exit on the highway and decide to go the opposite way. And so this is, again, sort of that variable penetrance that you talked about with your geneticist earlier, right? It's the expression of these genes is different for everybody. The deletion is different for everybody. So they're going to show in many different ways. But growth issues in this population are very, very common. And why is your baby not growing? We have 1,000,001 reasons as to what that may be. One, they were maybe just never meant to be big, right? A lot of these genetic disorders leave us with cute little babies, cute little humans, and that's just the nature of the beast. The opposite may be also true, right? Your child may have a predisposition for obesity, a genetic one, and so we see this sometimes. But this is one of the questions that I get a lot is why is my baby so small? They also have feeding difficulties, right? They have a really, really hard time handling and coordinating their mouth movements, their chewing, their swallowing, which leads to difficulty tolerating feeds. Some of them have cardiac disease. Cardiac disease burns calories like it's its job. And so sometimes those kids require fortified formulas. Sometimes no matter how good you are, how good they are at drinking, sometimes they require tube feedings as well. So seizures, very, very caloric intense as well, right? Contractions of muscles nonstop. Some of your kiddos have intractable seizures, so they may be having 10, 20 seizures a day. All of those things burn calories. And then kidney disorders can also do the same. On the opposite side of the spectrum, again, why is my child obese? Well, again, maybe they were just meant to be this large. Maybe they have a predisposition to overeating or to gravitating to a certain amount of food. There is a lot of maladaptive behaviors as well. They either see food as a comfort activity, or again that reduced sensation. They don't stop eating until they feel full. That's pretty normal, but their sensation of fullness is not like yours and I. So that could also be playing a role. Hypotonia, right? You're not contracting those muscles as good as well as you could. You're not moving as much. Hypothyroidism showing up again. We got to make sure that it's not a thyroid condition. And then fairly restricted diets that often favor sweets, high-calorie carbohydrates, that type of thing. G-tubes. If you have a child, a young one usually, and you're being told, that despite the fact that you're getting up throughout the night, feeding this child, getting them to eat, that it may not be enough. I don't want you to think as G-tubes as a failure. It doesn't mean that you failed as a parent. It does not mean that your child failed to meet its own needs. It might just be that they require a degree of calories, a degree of volume that they just cannot consume on their own. Do not see a G-tube as a failure. See it as something that it's part of the syndrome. It's part of the management. And don't see it as a permanent thing either. G-tubes, we take G-tubes out all the time. Sometimes they need to be replaced, and that happens. Most of the time, the kid is able to live without it. It'll leave a nice little scar, a collection, something to remember the G-tube by. But overall, they can make a huge difference in your child's hydration, in your child's seizure control, and your child's cardiac condition. So don't sleep on it, and have good conversations with your doctors, but they can be life-saving. Let's stop there. Questions about growth, questions about G-tubes, questions about any of the things that I just talked about.
Hi, my daughter's 2.5 years old, and we just recently went to the GI for the first time a couple months ago, and they always say she's failure to thrive. She's like 20 pounds, but she doesn't look skinny or anything, and she eats pretty well. So my question is just like, how Sometimes they say like we'll talk about maybe a G-tube in the future, like.
Yeah.
But I think she's a very good eater, but she's also does aspirate a lot and very picky and weird with textures. So how do I know like what's the best for her?
Yeah, are you working with a dietitian too? A dietitian or a nutritionist?
Yeah, she came in the room too. Yeah.
So that's usually, honestly, if I'm being honest, the person that I look to for help with those questions, because this is their entire training is about nutrition and growth, right? And so they know what to expect in individuals with genetic syndromes. But I got to go back to this. Remember, a lot of our kiddos start small and they remain small. All right, as long as things are symmetric, right? We don't have a long, lanky child where you can see the joints and the ribs, that type of thing. Then your kid is probably fine as long as they are all around small. Okay, that is very common for genetic syndromes such as this. I think the G-tube, the conversation is not one that you have in 15 minutes. It's not one that you have in a single visit. This is an ongoing talk. You talk about the risks, you talk about the benefits. Why are we placing a G-tube? Is it because we don't think that she's meeting her goals of feeds or calories or hydration? Is it just because maybe your GI doctor doesn't understand that your baby's not meant to be riding one of those curves, right? Because those curves are based on children with normal number of chromosomes, and so it's really important that you ask those questions. Why do we need a G-tube? What's our goal? And is my child growing appropriately? And your GI doc should be able to answer those questions with the support of a dietitian or nutritionist.
Hi. So my one peer also has something called Hirschsprung's disease. We are very close to getting a G-tube also. And I guess my question is, are there other ways to help them absorb the calories that they do take in that is not a G-tube? Like, are there supplements or like certain foods that help absorb more calories besides just like Pediasure or the regular things?
If you were in my office, the next question that I would ask you is, why not a G-tube?
I'm not opposed. We've been on a long journey. He was over a year old before we got the 1P diagnosis, so pretty much everything was being attributed to Hirschsprung's disease. We do a lot of other treatments, and I think some of the consumption is about the bowel movements, as you said. It's a cycle, so
You don't have to answer that question personally right now. The reason why that's my next question is because I want to learn what it is about the G-tube that either scares you or that makes you uneasy, or are you genuinely just want to know how can I optimize my child's nutrition? And if the question is how can I do that, is you're probably already doing a really good job at it, right? And so the reason that we gravitate towards these formulas is because they have not just the correct makeup of what we believe is a normal nutrition for these children, but also in a form that is easily digestible. If there are other issues like inflammatory bowel disease, if there is a concern for celiac disease, like these are the things that go through my mind when when a child is weight faltering, which by the way, that's the new term. We're really trying to move away from failure to thrive. It's weight faltering, which is what we're calling it now. And so as long as we're checking those things off and they don't have an inflammatory disease, they don't have some sort of other absorption issue. So for example, we think of lactase deficiency as just an annoying thing, but there are other types of disaccharidases deficiencies that we can test for. So you can be isomaltase deficient, for example, and that means that you don't absorb those specific sugars that are actually pretty common in a lot of these formulas and in a lot of the foods that we eat. So I would want to know specifically what workup we've done so far. Have we ruled out other things as to why they're not absorbing? Pancreatic disease can also be a reason why a child may not be absorbing fats really well. So all of those things go through my mind. And as long as those things have been checked off and we've thought about them already, then we can talk about specifics of how can we get your child to absorb the best nutrition without going for a G-tube right away.
Okay.
Keeping in mind that if we do need a G-tube, it is what it is, right?
Right.
It's a big choice. I don't want to minimize that. But in the grand scheme of things and the things that I see and that I do, that's one of the things that ends up actually having a really good change in the quality of life of the child.
Thank you.
Okay. We'll come back to growth and tubes, I'm sure, at some point. Let's talk about reflux here for a second. Reflux is a normal physiologic process, okay? The food pipe or your esophagus and the stomach are separated by a band of muscle called the lower esophageal sphincter. Anytime that you see the word sphincter, think of it just something that opens and closes. It's a band of muscle, all right? The LES relaxes from the second that you initiate your swallow to when you complete your swallow. That is about 6 to 8 seconds for the average adult person. So your lower esophageal sphincter is open for 6 to 8 seconds with every single swallow that you take. You are refluxing during that time. So when is reflux a problem? When does it become GERD? When you either are in clearing that reflux, when the reflux is very acidic or abnormally acidic, or when it's happening really often in inappropriate settings, such as during your sleep, when you're not necessarily actively swallowing or eating. And so this is specifically what we talk about with GERD, or gastroesophageal reflux disease, is when it starts eroding the lining of the esophagus, that is when it turns in, that's when it gets the D part, the disease part. Hypotonia keeps coming back, over and over and over again. It's crucial. We're talking about a tube, a muscular tube, the entire gut. That's all it is. I'm just a glorified plumber, I'm telling you. Hypotonia plays a big role in how well that lower esophageal sphincter is able to not just open and open fully, but also close and close fully, okay? And so we think it plays a big role in GERD. The medications that we put our children on, including those anti-epileptic medications, have a tendency to impact the motility of the gut, and that includes the lower esophageal sphincter. Delayed gastric emptying, otherwise known as gastroparesis, can also be a problem. Anytime that you're not clearing the whole system at an appropriate time, things have more of an opportunity to go back the opposite way. And then hiatal hernias. I don't know if you saw it on the first table when I told you what GI conditions are very common in 1P36. Hiatal hernia made that table. So they're at slightly higher risk than regular population. And so it's something that we think about when we're thinking about GERD in 1P36. Reflux treatment, we could do better. We have a lot of different types of the same medication, not types, a lot of different formulations of the same types of medications, but truly the two main medications that we use to treat reflux are your proton pump inhibitors, right? So your omeprazoles, your lansoprazole, all those fun ones, and then your histamine 2 receptor blockers, which are your famotidines that you can buy over the counter. So that's pretty much it. We do try to also manage it with lifestyle changes. That's mostly for sort of your babies with infant reflux and such. But there are things that you can do to try to improve, reflux, whether it's having them sleep upright, making sure that they remain upright after they eat or after they have a feed. That type of thing can usually at least minimize the damage that the reflux is doing. When all else fails, we are sometimes pushed to do a Nissen. And the Nissen is the name of the surgeon that made this very popular, but you might also hear it as a stomach wrap or fundoplication. These are anti-reflux surgeries that we were giving out like candy 30 or 40 years ago. And now we're realizing that we were probably doing a little bit more harm back then than we really should have. So you might hear some hesitation around this surgery. It's still a great surgery for the right patient, but we really should be looking at it as kind of more of a last resort thing. Vomiting and retching is not just GERD, okay? You have to make sure that your doctor knows how often it's happening, what are they bringing up, in what situations is this occurring? Is it after feeds? Is it before feeds? Is it after their bedtime? Is it before their bedtime? Because the pattern makes a huge difference, and they could actually have a completely different condition that is not reflux, and these are some of the ones that we think about. I'm pretty aggressive when it comes to my to my diagnostics of reflux. It's a condition that can be very painful, that can lead to poor tolerance of feeds, and it is exposing the child's esophagus to more acid and chronic inflammation, which eventually might turn into the C word, cancer. Obviously, that's usually not a concern for until they're like well into their 30s or 40s, but it is something that I want to make sure that we keep an eye on. And so I may do an upper endoscopy, I may do pH testing such as pH impedance or Bravo wireless capsule. And if there are concerning features, I may do some additional testing just to make sure that the esophagus and the stomach are doing what they're supposed to be doing. Questions about GERD, reflux, the Nissen procedure?
So my daughter has been on lansoprazole for years. She was on it twice a day for a long time, and now we are down to once a day. We tried to get down to every other day, but on the days that she was off, she was uncomfortable. We've done a GI workup. They did not do the pH thing, but she's been scoped. She's done all of that stuff. Is that enough to be like, yep, we need to keep her on it? Yeah. She is mobile. She's,
Right.
We've got a really good constipation protocol that we're using. Like,
Good.
we're doing all the things, but.
I think, so this is one of my biggest pet peeves in the work that I do is the polypharmacy and sort of all the different medications that become orphaned from whoever the initial prescriber was, and then nobody knows what to do with, and I don't want to step on the people's toes. I'm not going to discontinue it for them. So it's very important that you ask those hard questions, right? That you push your doctors to be like, hey, we've been on this medication for 3 years. Can we think about either weaning it or changing it or such? But there are situations where a child may be PPI dependent, right? And is it because they keep having erosive esophagitis or irritation of the esophageal lining? That one is pretty much an absolute. You have to be on a PPI, because otherwise that's going to turn into Barrett's esophagus and eventually esophageal cancer. That's a pretty big deal. So we're going to take whatever side effects the omeprazole, the lansoprazole is having, as long as we're protecting them from that. But if the endoscopies have been normal, and if we were to do a pH study and we recognize that maybe it's not happening as frequent as we think, or maybe something else, then it may not be a bad idea to wean her off of that, or wean them off of that, right? And sort of change it to as minimal as possible. So I'm curious if your child may be experiencing something called reflux hypersensitivity. So reflux hypersensitivity is this idea that for whatever reason, the esophagus or the stomach has a tendency to overreact whenever there is reflux there. And it could be acidic, it could be non-acidic. It doesn't have to be necessarily that it's actually doing any harm, but the esophagus is just a little bit more hypersensitive to it, right? It kind of jumps up a little bit too quick. So that could be happening. The way that I diagnose that is with a pH impedance. There's really no other way to do it. But the medication that those patients are on is usually a histamine 2 receptor blocker like famotidine, which is we see as kind of less problematic. Let's put it that way, right? But the PPIs are notorious for losing their owner and kind of just staying in the background forever. So think about those medications. They're they're probably fine. They're probably not causing major issues, but they do have a tendency to interact with other meds, so we have to think about them. And nobody's going to fault you if you tell your doctor, hey, why are we using this med? Can you explain that? Because...
Yeah, and my GI was recommending, let's get her down
Good.
as low as we can. We did talk some about going back on, famotidine instead. I guess where's the line there? Where do you decide to try to get her off lansoprazole and onto famotidine, or go through whatever the irritability and seemingly pain is to decide, is it this just this sensitivity, or do we really need to be on something?
I think it depends on how aggressive you want to be. If you feel like you need an absolute answer, then it may be worth to do the pH impedance. If it's one of those things where you kind of try something and see if it sticks, I think that's a reasonable way of doing it too. And so sort of putting on an H2 blocker and then slowly weaning the PPI in the background, that may do it. There is this thing where it's called rebound reflux or rebound gastritis, where if you taper somebody off of an omeprazole too quickly, they'll actually get the symptoms of reflux, despite the fact that they may not have it. And so I think you guys are doing a fantastic job that you've weaned them down to once every other day. But the other part of this is quality of life, right? If it means that she has to take this one medication that, all things considered, is actually pretty safe for her to enjoy her day and not have this constant gnawing pain, then I think that's worth it to me. As long as we revisit it every so often. Hey, let's check in. Do we still need this medication? Do we still need this medication, right? Because it does interact, especially with our anti-epileptics and in our birth control medication. So it's important to keep those things in mind too.
Yes, thank you.
Yeah. I'll open it up for more questions. I just want to say one last thing, okay? And that's mostly my concluding remarks. You are your child's expert, and don't let anybody else tell you that, okay? You know them best, all right? Help us, teach us about your child, okay? Let us know how they experience the world, because nobody's going to know that better than you. So sometimes the negativity or the negative interactions that you might sometimes have with a provider may not be rooted in necessarily malice. I don't think that I don't put on my shoes every single day to try to make your life difficult. It's just sometimes I don't live with a child that has this condition. I don't live with your child. Sometimes I literally cannot understand what is happening at home. And that's putting a burden on you, and I really wish that it wasn't. But let us help us understand your family dynamic and your children, okay? And eventually, hopefully, you'll be able to have a relationship with that provider and sort of grow along with them, and they'll also become an expert on your child. That said, there is a lot of misinformation out there. There is a lot of doctors that do not know about this condition. And again, the burden shouldn't be on you to educate them. They went through a very fancy, education themselves. They should be able to do this on their own. But with the way that healthcare is moving and the demand for doctors are these days, and shortening appointment times and growing wait lists, it's difficult for us to keep up with all of these conditions. So, have a go-to resource for this condition that you can disseminate to your doctor. And if they go and take time to read it, then you know that that's the right provider for you. GI concerns are common. They're disruptive. Get them a GI doctor that you're comfortable with. Even if you only see them once or twice a year, maybe it's not that big of a condition for your child, but we know that these kids are having GI issues. So bring them in, let us meet them. We'll work with you. If you don't need us, fantastic, but at least you have identified a GI doctor that knows about you and your child.
So our daughter is 11 months old and is showing some symptoms of GI problems where she does poop, but it's irregular, and we've been able to manage that a little bit. But one of the things that's been newer is that she kind of does like this like wriggling dance when she's on her back that kind of looks like somewhere between trying to do the hula hoop and something she saw in a Shakira music video. And I'm not totally sure if it's connected to some of her constipation. It doesn't seem to hurt her, but it does seem like it's discomfort in some way. And I wanted to know if you had seen that as part of constipation, and that's something we should include when we talk to our GI doctor in the future, or if this is something we should look somewhere else for, and that's not something you've seen.
It's also like as she's like starting to fall asleep, you know,
Yeah.
like it's like the muscles are relaxing.
Yeah, it's hard to piece that out, especially on an unverbal 11-month-old, right? They do a lot of quirky things that sometimes we just can't get a good sense for. So my first question to you is, it doesn't seem to bother her. Does it bother you? And if so, why? Are you concerned that there might be something else going on? Or, okay, all right. So if that's the reason, then I think that the second question would be, you know, how often is it happening? Oh, you know, like we would go through the entire history and try to figure out if there's a pattern and get to the bottom of that. Yes, it is a very common movement, sort of the hip gyrating and the lifting the hips off the table, especially for our babies that are not walking yet. That can be a sign of the infantile dyschexia that I was talking about before, where they haven't quite figured out which muscles to contract and relax to poop appropriately, or it could be a sign of withholding. Right, that this could be the way that she's preventing herself from going. So it's important to know how often she's pooping, how often she's doing these movements, and what it results in. Right? Are we talking, rabbit pellet poops, or are we talking about the opposite end, which is completely diarrhea? So those things are things that your doctor should ask you, and that you should tell them to try to get a sense of what it is. My guess is this is probably a little bit of withholding, and she'll get over it with time.
My question is kind of a two-part question. Our daughter was born without an esophagus, so they built her an esophagus out of a piece of her colon. So the first part would be, do I need to be concerned with this colon? Like, she definitely has reflux and sleeps upright. Is the colon going to continue to do the job of the esophagus? And then on the other side, by her missing a piece of her colon, is that going to create any problems in the future?
I'll answer the second question first because that's an easy one. No, she probably won't have many. If she hasn't had any issues so far with her colon, she probably won't in the future. This is for those the uninitiated ones. It's called a colonic interposition or a complete colonic replacement. And unfortunately, the colon is never going to do as good of a job as the esophagus. Right? We're talking about two completely different areas of the gut. We use the colon because it's easy and because we can live without it. Essentially, we can live without sort of the entire thing, and so that's the reason why we use the colon. But your doctor will make sure that colon piece doesn't get cancer, right? Because it is being exposed to acid, which is not something that it's used to. So one of the things that they will do is frequent monitoring with upper endoscopies to make sure that's not the case. And reflux, I'm not surprised that that's a concern, because you've essentially taken a nice firm tube that for the most part remains empty with a floppy kind of thin tube that has whose one main job is to store poop, and so has the ability to stretch. So it's not a perfect replacement, but yes, they will have more reflux. They have to be monitored a little bit more closely, and so talk to your doctor about what the plan is for monitoring and how you plan on protecting that interposition or that section of colon. I had never. Has anybody else heard of a patient 1P3 without an esophagus being born without an esophagus? This is why registries are so important.
I would be curious about that too.
Yeah.
And then she actually aspirated for quite a few months, and they eventually found an upper fistula in the little bit of esophagus she did have. There was a fistula over to her windpipe, and eventually, and they told us at the time, she's 18 today, so that was 16 and a half years ago, that it was extremely rare. And we'd be very curious if anyone else had the same situation.
Yeah, not something that happens very commonly in general. So I'm curious if the 1P36 has anything to do with that.
And Dr. Velez just talked
Hi.
about the importance of a registry. Just to let everyone know, there's going to be a talk this afternoon
Very excited.
about the registry.
Very excited.
You all should be there for that.
If your child has been diagnosed with dysfunctional elimination syndrome, do you recommend that they stay with a GI and a urologist, or is there a way to combine so that we don't have to add one more specialist to the entourage?
It depends on who your GI and who your urologist is, right? And their comfort level and how bad one disease is over the other. So if you felt like you wanted to consolidate care, then I would essentially stay with the person who's managing the disorder that is causing the issues the most, and that's usually the urinary tract, right? That's the one that's getting UTIs and pyelo, kidney infections. So typically, the urologist is the main person that's leading the charge, and they learn how to actually manage constipation fairly well, all the way to doing things like, antegrade enemas, the cystectomy stuff, and maces, and all those fun things that we can do. But if you have a GI doctor that is really privy to the effects of constipation on the urinary tract, then they may be the ones that lead the charge. And so, I'll give you an example. We have a complex elimination clinic. It's a subspecialty clinic in Michigan that is manned by a pelvic floor physical therapist, a colorectal surgeon, a GI doctor, a urologist, and a psychologist and a behavioral pediatric person. And we run into this all the time. And so we use that clinic to sort of as a place where all of the specialists can be at the same time and have the same conversation with the parent. So that's one other way that your institution might be able to help. So ask around. Usually the patients that go to those clinics are patients with like spina bifida or myelomeningocele, sort of the lower spinal cord injuries. So you may be able to get into something like that by going down those routes.
I think one more question.
Hi, so it's two-parter kind of. So the twins, the moms here, we have a lot of the same issues. And one of the biggest issues is mucus. And for us, at least, we've tried everything under the sun. And GI points a finger at ENT, and ENT points a finger at GI, and everybody just kind of throws their hands up and goes, I don't know what to tell you. We've done Botox injections, famotidine, cyproheptadine, GABA, like everything, the pH probe. And at this point, I feel like, and we've even done the GJ, and we ended up weaning off the J because I felt like we were still dealing with the retching and then going blue at that point. And at least with the G, he can throw up the entire stomach contents, and then he clears the mucus. And so at what point do you really start going, okay, is the Nissen the next approach, or do we go back to a GJ? Or because we're also dealing with pulmonology going, well, he is aspirating on a regular basis. And so it's just this constant, I don't know if I'm ever making the right choice, and how do you figure that out?
Yeah, also a very common thing that we have to deal with, and it's so common that a lot of the larger children's hospitals now have what's called an aero digestive program. So aero being sort of breathing, and digestive being digestive, and usually it's made up of a gastroenterologist, a pulmonologist, and ENT doctor, and they again have similar multidisciplinary clinics where they will all three will get in on the same page and not argue about who's who. It kind of reminds me of, I don't know if you've seen that Spider-Man meme where it's like 3 copies of Spider-Man pointing at each other. I get into that all the time because it's really hard to tell whether it's the respiratory system that's maybe overdoing it with the secretions, that's overdoing it with the mucus. Is it a swallow discoordination issue? Is it a larynx, a Boyce Vox issue? A vocal cord issue? Or is it just the reflux is so bad that you're putting sort of this entire complex to test every time that you reflux, and sometimes that's going to turn into an aspiration pneumonia. So, if they have done, from what I hear from you, which sounds like a very complete workup, I think it's time to actually sit down and say, is this ongoing reflux, which we think is what's causing the aspiration pneumonia, is this ongoing reflux that big of a risk? And are we having multiple admissions a year for aspiration pneumonia? Are we having an unexplained chronic cough or sort of that wet cough after eating? And are they having trouble managing those secretions? And what impact is that having on the respiratory health? And what impact is that having on the digestive health? Right? Are we having a lot of erosions in the esophagus? So those are the things that I take into account before I send somebody to a surgeon for a fund application, for example. And so I need to make sure that, if all of those things are normal, are we doing the fund application as a quality of life thing, which is a reason alone or enough to do a fund application. I think that's fine. But we really have to make sure that it's, before we make that decision, that those things have been at least looked at. And it sounds like they have. So if it continues to be as difficult of a problem to deal with, a fundo is probably the next step, and not unheard of. Like I said, we used to do it a lot. I think we're being more cognizant of when we do it and how we do it. So you may see a little bit of resistance, or they might want to do a few other things before they do it, but I think that sounds like a very reasonable next step.